Every year, geriatric medicine experts publish an updated list used by doctors and pharmacists across the country of medications that deserve extra caution in adults over 65. It's called the Beers criteria, and one entire category on that list exists because of a single specific concern. Certain very common medications can measurably affect memory and thinking in older adults, often so gradually that neither the patient nor their family connects the dots. We're not talking about rare, obscure drugs. Several of the medications on this list are available over the counter, sitting in millions of medicine cabinets right now, taken for sleep, allergies, or bladder control. Today, we're walking through 6 categories of medication that geriatric research has linked to cognitive effects in older adults, what the research actually shows for each one, including where the evidence is strong and where it's genuinely still debated, and what to bring up at your next doctor's visit. Let's get into it. Several of today's 6 categories share a common mechanism worth understanding up front. They interfere with a brain chemical called acetylcholine, which plays a central role in memory, attention, and learning. Drugs that block acetylcholine are called anticholinergics, and while a single dose usually causes only mild, temporary fog or dry mouth, research has increasingly focused on what happens with regular, long-term use in older adults, whose brains are already more vulnerable to this specific disruption as part of normal aging. Not all 6 medications on today's list work this way. A few affect memory through different mechanisms entirely, like sedation or blood chemistry changes. We'll be specific about which mechanism applies to which category as we go. Diphenhydramine, the active ingredient in many over-the-counter sleep aids and allergy medications, is one of the most strongly anticholinergic drugs in common use. It's also one of the most accessible since it doesn't require a prescription. Research using the anticholinergic cognitive burden scale has consistently linked medications in this strongly anticholinergic category to lower scores on tests of global cognition, learning, memory, and executive function in older adults tracked over several years. The American Geriatric Society's Beers criteria specifically flags diphenhydramine as a medication older adults should generally avoid for routine sleep or allergy use, precisely because of this cognitive burden concern. Oxybutynin and similar medications prescribed for overactive bladder work by blocking the same acetylcholine pathway. That's actually how they calm an overactive bladder muscle. But it means they carry meaningful anticholinergic burden as well. This category specifically now carries an added caution for patients already taking medication for dementia, since combining a strongly anticholinergic bladder medication with a cholinesterase inhibitor, a common dementia treatment that works in the opposite direction, can directly work against each other and potentially worsen cognitive symptoms. Not all antidepressants carry this concern equally. Paroxetine and older tricyclic antidepressants have meaningfully higher anticholinergic activity than many newer antidepressant options, and both appear on anticholinergic burden scales used in this research. This doesn't mean these medications are wrong for everyone. For some patients, they remain the most effective option. But it does mean this is a specific named category worth a direct conversation with your doctor about whether a lower anticholinergic burden alternative might be appropriate for you. Benzodiazepines work through a different mechanism than the drugs above, sedation rather than direct anticholinergic activity. But the American Geriatric Society specifically recommends avoiding this category in adults 65 and older due to increased risk of cognitive impairment, delirium, falls, and fractures. We want to be precise here, because the research on benzodiazepines and long-term dementia risk specifically is genuinely mixed. Some large studies have found an association between benzodiazepine use and increased dementia risk. Several other well-designed cohort studies have not found that same association once other factors were accounted for. What's more consistently supported across the research is short-term cognitive impairment and fall risk. The long-term dementia connection remains an active, unsettled area of research. Muscle relaxants like cyclobenzaprine also carry meaningful anticholinergic activity and appear on the same Beers criteria caution list as the categories above for the same combined concerns: sedation, cognitive burden, and fall risk in older adults. This category matters especially in combination, SUX, research on cumulative anticholinergic and sedative drug exposure has found that the more of these medications a person takes together, the higher the measured impact on cognitive decline over time, tracked using a tool called the Drug Burden Index. This last one deserves the most careful, honest treatment of all six, because it's a story of science correcting itself in real time. Several years ago, a widely discussed study raised concern that long-term use of proton pump inhibitors, common acid reflux medications, might be associated with increased dementia risk. Since then, additional and more rigorous research has actually walked that concern back substantially, with several more recent larger studies finding no clear causal link between PPI and dementia once other factors were properly accounted for. We're including this category specifically to show you how good health information should work: an initial concerning signal, followed by more research, followed by a more nuanced and reassuring picture. If you've heard the PPI dementia claim before, the most current evidence is considerably less alarming than when it first circulated, though PPIs carry other well-established long-term concerns like effects on bone density and nutrient absorption that are worth their own separate conversation with your doctor. Here's the single most useful step. Bring a complete list of everything you take, prescription and over-the-counter, to your doctor or pharmacist, and specifically ask them to calculate your anticholinergic burden score. This isn't an obscure request. It's a standard clinical tool many pharmacists already use, and most are glad to walk through it with you. If you're taking something like diphenhydramine for occasional sleep trouble, ask your pharmacist about lower burden alternatives. There are often other options for the same symptom with a smaller cognitive footprint. If you're on several of these medications together, that combination specifically is worth flagging, since the research shows the effect appears to add up with cumulative exposure. Please do not stop any prescribed medication on your own after watching this. Some of these, particularly benzodiazepines, can be dangerous to stop abruptly and require a doctor-supervised taper. This video's job is to help you ask a specific, informed question, not to make the decision for you. We want to be straightforward about something most videos in this space skip over. Much of this research is observational, and several studies note a real complicating factor called confounding by indication, meaning the conditions these medications treat, like insomnia, anxiety, and depression, can themselves be early symptoms of the same cognitive decline researchers are trying to measure. That makes it genuinely difficult in some cases to separate this drug-caused cognitive decline from this drug was prescribed because early cognitive decline was already starting. The strength of evidence also varies significantly across these six categories. The anticholinergic burden research, particularly for strongly anticholinergic drugs like diphenhydramine and oxybutynin, is fairly consistent across multiple studies. The benzodiazepine dementia link is genuinely mixed, and the PPI dementia concern has been substantially walked back by more recent evidence, which is exactly why we included it as a case study in scientific correction rather than a settled warning. The honest summary is this: these six categories are the ones geriatric medicine's own established guidelines, the Beers criteria, flag for extra caution in older adults, for reasons ranging from strong, consistent evidence to genuinely unsettled ongoing research. That's a meaningfully different, more honest picture than treating all six as equally proven dangers. So here's the recap. Over-the-counter sleep aids and allergy medication, bladder control medications, certain older antidepressants, benzodiazepines, muscle relaxants, and proton pump inhibitors. Six categories that geriatric medicine's own guidelines flag for a closer look in adults over 70, with evidence ranging from well-established to still actively debated. If several of these are sitting in your medicine cabinet right now, that's genuinely useful information. Not a reason to panic and not a reason to stop anything today. It's a reason to have a specific, informed conversation at your next appointment. And one more time, because it matters, please don't change any medication based on this video. Bring this list to your doctor or pharmacist and ask them to review it with you. If this kind of research-backed breakdown is useful to you, consider subscribing. We go through published guidance like this every week, always with sources, always without hype. And if you know someone whose medicine cabinet has grown a little every year without anyone reviewing the whole list together, this might be the video worth sending them today.